Don't forget, it is a medical operation. You need a pulse oximetry and you need an emergency trolley when you're operating. Clear of your surgical goals, achieving best possible function with the optimal appearance, maintaining the sensitivity of the area, and always evaluate labia minora. As I have already told you, in many cases it is labia majora which is culprit and need correction. Supposing on the table you realize this thing, that her labia majora is very flattened. How you are going to do the labia minora plasty? Maybe you cut more. So put a saline in the labia majora, plump it up, and see how much is really protruding out. And operate that and tell that patient that she needs an labia majora augmentation. But if you have properly examined patient in all way, in his standing, in lying down, then mostly you are not able to land up in this type of the situation. So as is, there's no ideal appearance is available. It's patient's own preference. What I was talking about to you is the this hanging. If you don't address the upper labia minora, which is making a cover over the clitoral hood, and you just operate down, right behind, right, start seeing your all patients with chain, examine them. It will give you a clear idea what you are going. And activity restrictions should be given and the refrain from the sexual intercourse for at least 6 weeks, maybe more also, depending upon the operation. For the managing swelling and pain, ice packs are very good. Use a donut pillow, oral antibiotics if required. So when to seek medical attention, severe pain, excessive bleeding or foul smelling discharge, sign of infection, difficulty urinating or significant swelling. So in nutshell, patient selection, especially in relationship to reasonable expectation, is crucial. Also, of paramount importance is pointed out by the Leo and the is as considered an evaluation of the motivation as possible. This thing is very necessary. What is the motivation? So my role as a designer is to make a woman feel her very best. That is the mantra for the aesthetic surgery. But we are doctors. We have to really never cross the line, which is between a beauty salon and a doctor. Thank you so much for your patient hearing.
Thank you. Thank you so much, ma'am. Dr. Kiran, sir.
Yeah, it was a fantastic talk. Apt talk, Dr. Angini. There are few questions for you.
Yes. Yes.
One is where to get the plastic models of the external genitalia in case we want to explain something to the lady. Do you have any site where we can get the plastic models of the external genitalia, labia majora?
हाँ नहीं है.
I also searched on the Amazon, but no, on Amazon or
Listen,
India Mart
how
also it's not.
how I explain them. You take out the printouts,
Hmm.
and on a silicone sheet, you attach it, and then stand it in front of you, and you can tell the patients. I am not able to get any this thing. And some doctors I know, they have made their own clay models and all. So if in your city some person is there, you can make. Somebody has written, my voice was low. My voice is really low.
No, the Ragini, you're fine. No problem. I mean, at least my voice is very clear. Probably you speak softly. That's okay.
बीच में थोड़ा सा था but majorly was okay.
कोई बात नहीं, जिसने लिखा है मेरे से दोबारा बात कर लेना. मेरे ख्याल से तो डॉक्टर कृष्णा कुमार के यहाँ का नंबर है. Any other question?
Any other questions for Dr. Ragini?
No. So,
Ma'am, you have explained each and everything in minute details. And so there are no questions for you.
okay.
And thank you very much.
Okay, ji. Okay, thank you. Thank you so
Very
Thank you.
nice
Thank you, Doc.
presentation.
much.
Yes.
Thank you, Dr. Ragini, and I'm sure that many of us would love to be there with you, all of you in Chandigarh. I've already shared the brochure, and in fact, I'll share the brochure in all the WhatsApp groups also of ABOX. And of
Thank
course,
you.
Milind is also there, so I would request Milind also to do the needful.
Yeah, Milind is an incoming secretary.
Yeah.
Okay. Okay. Thank you so much.
Okay. Thank you so much.
I'm there, very much there, but I will अपना video रोकूंगी. Okay?
चलेगा.
Very.
Yeah. Yeah.
We have. Sir, can I proceed?
Yeah. Please do.
We have a very next speaker, Dr. Preeti Jindal, with us for labia majora plasty.
So shall I share the video?
Yeah. 1 second. Meenal, would you see the screen?
Yes, sir. Yes, sir. Dr. Professor Preeti Jindal, she is past president of Mohali Obstetrics and Gynec Society. She is senior consultant OBGYN, Fortis Hospital, Mohali. High-risk pregnancy, recurrent miscarriage and IVF treatment specialist. Professor in the Department of Clinical Embryology and Reproductive Genetics at Rayat Bahara. Laparoscopic, hysteroscopic and robotic surgery expert and cosmetic gynecology. She is ex-PGI Chandigarh, ex-senior fellow St. Mary's Hospital, London. And there are many more to her CV. So to you, Dr. Preeti ma'am.
Thank you so much, Dr. Milan. Thank you, Dr. Kiran, for giving me this opportunity. I'm not able to share my screen, please.
You will be able to. You will be able to now because I have stopped sharing. You will be able to share.
Okay, let me
आप
try.
try कीजिए, हो जाए.
Yeah. Perfect. So there we go. Right. So are you able to see the screen?
1 second, madam. Now we are able to see. You can
Perfect.
start. Yeah.
So, as Dr. Meenal has said, I do just like all of you, and most of here are gynecologists. So you all are hardcore gynecologists, and so am I. And cosmetic gynae, which I picked up in 2017, is basically my passion. When I'm very tired of robotic surgery and IVF and all, and then when I moved to the aesthetic gynecology, I really enjoy it and I do it as a passion. And as you have rightly said, Dr. Kiran, ABCD, the same thing. I have started since last 2 years that every gynecologist should be a cosmetic gynecologist, and they are. It's just about recognizing your own potentials. So we move to our main core topic, labiaplasty. So labiaplasty could be labia majoroplasty or labia minoroplasty. My topic is labia majoroplasty, so we will stick to that. So first of all, as Dr. Ragni has already explained in great detail, nowadays why we see why is there suddenly interest in aesthetic gynecology? I remember Dr. Kiran in 2017 when I picked up this branch. I actually did not like to pick it up. My husband, he is a well-renowned vascular surgeon, and Dr. Rahul Jindal, and he has been using laser for many, many, many years. And when he used to visit different conferences, he would come and tell me, see, something is happening about vaginal laser. Why don't you do it? And I said, what? I said, no, I do high risk obstetrics. I do robotic surgery. What is this? I will not do it. And second reason was there was an inherent fear about the laser. So, but then when I got trained and I started doing it, I still remember in most of the places there was no workshop on aesthetic gynecology, and we have really come a long way from there. And in 2019, we did first interdisciplinary aesthetic gynecology conference in Chandigarh by the name Cosmetic 19. And that was the first time I remember in my conscious memory that whole India was involved, and people started talking about it in a nice way. Earlier, it was looked down upon, and now over next 7 8 years, in every conference we are having workshops on cosmetic guiding. So the increase in awareness has led to spread of this knowledge. Then secondly is the social media. Social media has worked a lot because the women are becoming financially independent, and when they see the Bollywood stars and they see the Hollywood stars and they compare their bodies and all, and they think, why can't I have such lovely body? So, and what's wrong in it? Secondly, it has been seen in the scientific studies that the pornographic sites visit by the females is much more than by the males, and it is actual data. So when the women see it, they don't, maybe they do not see it with the mindset of the males, but then they see it in a mindset that why can't they have such a body? I always say the vulva should be as beautiful as your face, because your face is looked by you, vulva is looked at by your partner. So it there is full right that vulva should be beautiful. And we are very surprised that most of the women, they have never seen their vulva. They're so, I don't know what, they are so tabooed about it. So one thing I always tell the women who visit my clinic, I always say that today you go back home and put a mirror and have a look at your vulva, and you will know what I'm explaining to you. So this is something which we should try to teach our women, that they should not be ashamed of their own body. It is so important. Then, of course, there is something new going on in America and in South America, Brazil, that's called the Barbie look. So the Barbies, they do not have labia majora. So nowadays, that is very much in common, that they are clipping off the labia majora, and many women, they come with the request that they want a Barbie look, and they are coming to us in India also. But that part is different because we follow very ethical medicine, and there is a very fine balance between genital mutilation and cosmetic gynae. So you have to remember that if genital mutilation or anything which comes under genital mutilation is punishable by law. So when you are doing a labiaplasty, you have to be very careful what you are offering to the women. So these are the two books. I would just like 1 second to let you know about them, because if you are following the path of cosmetic gynae, then this was the first book published in India, and it was published. I was one of the editors along with Dr. Naren Malhotra, and it was published by Springer Nature. This is like a Bible of aesthetic gynecology. So if you really want to pursue this field, this was one of the best Amazon seller at a time. So you can order it from the Amazon or Springer site. And last year, I published this book. I'm the editor of this book from Aesthetic and Regenerative Gynecology, which was published by JP Publishers. So if we think Springer, that is like a tea length. And this one by JP Publishers is like Datta. So you can decide which you have to read and you can go ahead, right? Now coming to, somebody was talking about that, to where to get the molds. Have a look at this picture. This is the Great Wall of vulva actually, but it has been labeled as vagina. This is not vagina, this is vulva. This was a plaster of Paris creation done by Jamie McCartney in Brighton. Brighton is a very beautiful place in England, and there was an artist, Jamie McCartney. So what he did, he took 100+ women and did the plaster of Paris model of their vulva and made a wall, and it's become a great art piece nowadays, and it is known as Great Wall of Vagina. The main aim was that just like the faces are different, same way the vulva are different. So there is nothing right or wrong. It is more about what look you want. So all these different types of vulva which you can see, they come within the normal limits, right? So if a woman comes and says that I feel my vulva is not like this picture, you can show her this and you can tell her that this is just totally normal. Every woman has a different vulva. Now, still, if a woman says that she is not happy with her labias, then comes the role of labiaplasty. What is labiaplasty? Labiaplasty is a surgical procedure for altering the shape and size of labia minora and labia majora, the folds of skin surrounding the human vulva, to enhance the look and functionality of the female genitalia. And vulvovaginal surgery is also known as labiaplasty in a broader sense. It is one of the most asked for cosmetic gynae procedure in the Western world. And even in my practice, not that common, but then still in a month, we do get requests, 2 to 3 requests for the labiaplasty. Then what is the purpose of doing it? As I just said, it is for the aesthetic and functional reasons, also enhancing the appearance and reducing the discomfort. I once had a pilot. She had come and her labia minora was that big that she was not able to wear her jumpsuit. So then we did the labiaplasty and then it was relieved. And so it's not only for the aesthetic purpose, also for the functional. Sometimes labia minora, they're that big that intercourse is not possible. So you have to do the labiaplasty for their functionality. Coming to the anatomy of the vulva, so just to revise quickly, labia majora are the larger outer lips. These are the labia majora. They are basically pad of fats and they are outer lips that protect the clitoris, urethra, and vaginal opening. Labia minora are the small inner lips. These are the flaps, skin flaps, which are located between labia majora and also between the introitus. The normal women's labia, they vary greatly in size, shape, color, and thickness. And when a person is sexually aroused, the labia majora can expand to 2 or 3 times their regular size, making them visible or buried. The glans clitoris is directly beneath the prepuce. Here is the glans, if you can see my arrow. And directly beneath the prepuce, the frenula are skin folds that stretch from glans clitoris and unite with the clitoral hood above to produce labia minora, which goes all the way down and meets near the introit in the posterior fourchette. Then there is internal circumflex artery and external pudendal artery and internal pudendal artery. All these have branches that give blood to the labia minora. So when you are doing a labia minora plasty, you have to be very careful about the vascularity of labia minora, and that will be covered in the next lecture. The posterior labial nerve, which is a continuation of pudendal nerve, innervates the labia minora. So again, the indications could be cosmetic, could be functional, or could be medical. Hypertrophy of labia minora or majora may lead to irritation, regular infections, and difficult to maintain the hygiene. So coming to the labia majora plasty, first we will talk about the surgical plasty and then we will go for the non-invasive methods. So in the usually surgical labia majora plasties are usually not required, and very less we do it. We usually do non-invasive lots of labia majora plasty, but not the surgical. Labia minora plasty we do a lot surgically. So main aim of the labia majora plasty is to achieve symmetry. Any cosmetic procedure, you have to understand you are doing a cosmetic procedure, so it has to look good. And human eyes always perceive symmetry in a nice way. So whatever you try to achieve, try to maintain bilateral symmetry. So draw a line from top of clitoral hood to labia to the posterior fourchette on both the sides. And the aim of any labia majora procedure is to cover the introitus. it should be able to cover the labia minora just as it is in the small kids. If you see a small girl, a prepubertal girl, their labia majora are full of fat and it covers the introitus. And if you compare it to postmenopausal women, the labia majora, they become very flaccid, just like flaccid balloons. So the introitus becomes gaping, labia minora starts being visible, and even the urethra, you can see gaping urethra from the if you do the inspection. So the aim of mainly labia majora plasty is to cover the introitus. And if there are two, but at the same time, in the Middle East, I take lots of lectures in the Middle East, and I do get patients from Middle East. There they have a lot of fat in their labia majora, and they want them to be little more thinner, and especially the mons pubis, because of the weight, the mons pubis is hanging, and the labia majora are very plump. So there we do mons plasty. We remove the fat from the mons pubis, and on the simultaneously we remove the fat from the labia majora. Then minoroplasty can be combined, and yes, and most of the cases labia minoroplasty can be combined in the same sitting depending on the experience of surgeon. But if you do not have that expertise, then please do them as separate procedures, because once the labia minora breaks down, it appears to be a very small procedure. Many times we think we are doing hysterectomies, we are doing oncosurgeries. What is labia minoroplasty? But believe me, if the labia minora gets infected and minoroplasty gets infected, you will have it, because the first thing is the patient is getting it done for the cosmesis. Secondly, they do not have time. Thirdly, they do not want people to know about it. And if they have to make multiple visits to your center, you can imagine those small thin flaps of skin, they are infected. You do not have area to work on, so it really becomes a nightmare. Now, labia minora hypertrophy classification, I'll just quickly tell it because it will be covered in the next lecture. There are multiple classifications, and the basic thing you have to remember, if it's protruding more than 2 centimeter beyond labia majora, then we say it is extra large and we need to do a labia minora plasty. Now, coming to the main thing about labia majora is the non-surgical approach, and we have so many things to help in the non-surgical approach. So, starting from the fillers, hyaluronic acid. So, if you are aware, I'm sure you had one of the lectures on hyaluronic acid or fillers. I'm sure Dr. Kiran, there must have been a lecture or it's about to come. So, there are two types of
It was.
yeah. So hyaluronic acid is known as the filler, and you have the cross-linked and non-cross-linked. The what you have to use cross-linked, what does it do? It makes it long-lasting. So if you are doing a labia majora augmentation, you need to put cross-linked hyaluronic acid, and it is long-lasting. It moisturizes it also, and it makes the labia looks very beautiful, and it's very easy. I think I have a video I'll be showing you, but you have to remember it's very expensive. So labia majora, if you have to put the hyaluronic acid, you have to put 4 ml on each side, and you have to put it in a way that you put 1 ml, then 2 ml, then 1 ml, so that you have a proper elliptical shape, and it should not be blotched thing. So it becomes very expensive proposition, 8 ml of hyaluronic acid. So what else can we do? We can put platelet-rich plasma. So I will be telling you about PRP and how to make it very simple procedure. Then we can use the energy-based devices like CO2 laser, RF, radio frequency, and nowadays even exosomes are available, and amniotic fluid and stem cell injections can be done within the legal purview. You need to have the legal licensing to use all these products. So what are the contraindications? Although wanting a labiaplasty is a personal decision, but you have to understand you are a doctor and you are the one who is offering it anyway. You are the one who is doing it. So please ask again and again. Ask them to get the picture of what their own picture, and ask them what you want it to look like, because most of the time they have just seen, there many times they are the young girls or the girls between say 28 years to 38 years. They are working in high profile companies, they have lot of money with them, and then they go out for those parties, they discuss, and they come back, and without knowing what they're asking for, they will come and say that we want labiaplasty. Then you explain them nicely, spend at least half an hour with them. It's very difficult in the busy clinic, but it will help you in the long run. Never do it in the first sitting, never ever do it in the first sitting. tell them, you explain the procedure, and then ask their permission, take a photograph in their own phone of their labia and give it to them and say, this is what you look like. Now you get me a picture from the Google or from wherever you have seen what image you want, right? Then schedule a second meeting, second consultation with them, and then again discuss about it and tell them, once it is cut, especially for the labia minora, once it's cut, it will never be sewed again. So one has to be very careful. And then still, if she wants, place her on the third time. Then do the surgery or procedure the third time. Non-invasive procedures, you can go ahead because they are not long lasting, they are not permanent. But cutting anything which you cannot sew back, please be very careful. And you should be aware of a condition known as dysmorphic body syndrome, where women is never satisfied with the body look. And then if you land up with one such type of patient and you have done a procedure on her, then you are stuck for the life with her. So make sure you know what she wants and she knows what she wants. Then of course there should not be active genital infection, STDs, gynecological cancers. Do not forget your basic. Do a pap smear. Definitely do a speculum examination that there is no infection. Then give her the realistic aesthetic goals. And smoking leads to breaking up the structures. We all know that any infection, healing gets retarded if they are smokers. In pregnancy, we don't do any such procedures. And coagulation disorder. Always do CBC and coagulogram. That is the basic. Do the viral markers. Hepatitis C and HIV, they are so rampant, especially in such people who are coming for these procedures. We do not know their sexual history. So do not go for a shortcut. No, never. Then the medical legal implications are always as they are there. So Dr. Ragni has already discussed. It is a non-emergency procedure, so it has got much more medical legal implications. There should be written consent, and in these books also we have put the consents, and then when we do the courses we give a manual in which there are all the consents. If you want, I will be able to send the consents. um, Always take a proper written consent, explain properly, again think, and visual clues about the results. Labioplasty will be discussed. There are lots of things. And this was a patient in whom I did the labioplasty as well as the minora and major plasty together. So these were her labia minora, and I did her labia minora plasty, and this was the look. So you can see, yes, definitely to my eyes, they look better. And same way, the other patient here, these were her labia majora. These are very common. These are two types I have shown because these are the commonest type of labia minora which you see, which are hypertrophied. And this was after the result. And you can see this fullness also because I did her non-invasive labial majora augmentation in the same sitting. So this was labia majora plasty again and combined with labia minora plasty. So you can see before and after picture, and it was just immediately after. So you can see some stitches here also. So recovery time usually after the labia majora minora plasty is 1 to 2 weeks, but sexual activity should from the lower end or you go from the above end. I prefer to go from the lower end. So just near the introitus here, I make an opening with a small, we give the local. And then with a small needle, we make an opening hole, and then we have to use a cannula. Please do not use spinal needle, because spinal needle is very sharp, and you all have seen vulval hematomas in deliveries. So please do not take any procedure lightly. So these are dermal cannulas. You get them very easily. So most of the dermatologists, they use it for the face and everywhere. So you just thread the cannula through from here. It goes subcutaneously. It goes up till here, and then start injecting your PRP or HA or fat, whatever you want, and slowly keep on withdrawing it. So what I normally do, I inject around 2 ml over here, then 4 ml in the center part, and then 2 ml. So you get a nice elliptical curve over here. So this is the procedure, and the small pinpricks come, and no suture is required, and patient goes home immediately. And always take before and after picture, because for the beauty, the thing is, once it becomes beautiful, the patient thinks they forget the previous picture, and they think you have not done anything, and they want it more beautiful. So always show that this was before, this has become now, and then next whatever we'll do, it will become like this. Labia minora plasty, we leave it to the next person, and there are different ways of doing veg and de-epithelialization. Just one thing I would like to say, I always do the veg plasty, because that is one of the best. It gives the best results, and the color of the labia minora is maintained, because if you see labia minora, there is hyperpigmentation on the top of labia minora. So if you just do a linear cut, or you make it zigzag, I don't know who does it. I mean, it is so, so not to be done. So if you just chop it, you just chop it, linear chopping. So what will happen? That pigmented area will go. And so the color of the labia minora will become totally hypopigmented. But when you do a veg resection, it will look more natural, and the scarring is less. Then laser labiaplasty is nothing. It's same thing. Instead of using the knife, you're using the laser, or you can use RF knife. That is known as laser or RF labiaplasty. There's one more thing. RF labiaplasty nowadays, radio frequency, though I did not find results that good, but those who have been doing this say that with the RF, you can actually decrease the size of labia, but little far-fetched, yes. Now coming to the mesotherapies, PRP. What is mesotherapy? Mesotherapy is a Latin word. I think I have 3 more minutes. So basically, it is about the PRP I want to talk about. So PRP is now known as golden elixir of life. And it is very easy. Why is PRP used everywhere now? Because it is believed that platelet rich plasma has got lots of growth factors, vascular, endothelial, then you have insulin growth factor, and fibroblast growth factor, epithelial growth factor. So you name it and you have it. So you can use it. I use it a lot in the ovarian PRP during my IVF cycles for the low AMH, and I found very good results. So same PRP. When you prepare, it's very easy to prepare. If you have a lab, 10 cc of blood is taken, 10 or 15 cc, depending how much you want to prepare. Make it stand. And then first is a soft spin, and then is a hard spin. So first revolution can give 1500 revolution per minute for 10 minutes. It gets separated like this, the yellow part above, which is platelet-rich plasma with a little buffy coat. So you take this whole yellow thing out, and you can see the platelet pellets below, and this is the platelet-poor leukocytes. So, and the plasma. And then give it a hard spin. Double the revolution per minute as you did in the first one. So 1500, now 3000, and do it for 10 minutes, and you get platelet separated pellet down below, and you can suspend it in as much of plasma you want. I don't waste even single amount of plasma, because even a small amount of plasma will have some platelet growth factors. So I use them a lot everywhere. If nothing, then I just put it in the vagina only. So it helps in vaginal rejuvenation. I use it in the cervical ectropion. If bad cervical ectropion, you inject the PRP, and they miraculously they become okay. Even HPV infections, I use a lot of PRPs. So we will just skip the PI. I've already told you the important point. It has to be collected in citrate bulbs and not in EDTA. And yeah, so you can inject the PRP. I don't think the video is here. I'm so sorry. I might show you sometimes else. And we do lots of hands-on training courses, and the aim is the same. Every gynecologist should be a cosmetic gynecologist. And I would really like you to invite to our very beautiful conference, CosGyne 25, which we are having on 14th, 15th August, and with lots of workshops on 16th August. It will be covering not only cosmetic gynae, it will be covering latest advances in obs gynae, infertility, and IVF. And for the resident doctors, we have just kept 5,000 registration charges. So basically, it's very nice, and we are here to welcome you to City Beautiful. Thank you so much, and I hope you enjoyed this quick session. Thank you very much. Thank you, Dr. Kiran.
Thank you. Thank you so much, ma'am. And there are some questions, ma'am.
Sure.
Ma'am, which HA filler you use and reference of the company and cost?
Company I cannot name. Any HA filler is fine. You have 3-4 companies, and all of them are good. And but only thing is, you should use a cross-linked, which can last for a longer time. The non-cross-linked, they get absorbed very fast. So those you can use for G-spot augmentation, U-spot, all these shots for them you can use. But for the long-lasting effect, you should use the cross-linked HA. Cost depends company to company.
Do you advise sitz
And
bath for all these patients?
Not at all. No. No sis baths. Just keep the area clean. Just wash it and just keep it dry, and they can apply B. See, for the labia, Dr. Kiran, there's just 2 spots only. 2
Okay.
small entry points.
So,
You can apply B-back.
this procedure, for how many days should they be sexually inactive?
If you are doing only labia, there is no need of say abstinence,
Oh,
but
abstinence.
labia minora, 1 month.
Meenal, anything else?
no, sir. Ma'am, you have explained so much wonderfully, sir. Ma'am, and thank you very much.
Thank you so much, and thank you for the opportunity. Thank you, Dr. Kiran. Thank you,
Okay.
Dr. Meenal.
Uh,
Really
Dr.
happy.
Preeti, there are 2 small questions. What is exactly cross-linked and non-cross-linked?
Okay, so this goes into their the way they are prepared. So if we go into the microscopic and into the biochemistry, so cross molecular structure, if we remember our chemistry, there were bonds. So if they are strong bonds, they are called cross-linked. So they do not get broken very fast. And non-cross-linked are short-lasting, but they are cheaper. So it's more about their biochemistry. And then cross-linked are more hygroscopic. In labia majora or anywhere you want augmentation, even on the face or anywhere, you want hygroscopic fillers as well. So they are more hygroscopic as well.
How do we create the entry point? Just a stab knife?
No, with a needle, I use the thick needle. You can use 16 gauge or 18 gauge needle. With that, you make an entry point after after putting Prilox.
Okay.
Yeah, and you put Prilox for half an hour, the area becomes numb, or you can just put a lignocaine injection. And then with a thick needle, you just make a little entry point and just remove that needle and then thread your cannula in.
So these cannulas are readily available, right? Dermal
Yes,
cannulas.
yes.
Okay.
All dermatologists use them.
Okay. Now, for reduction of mons and majora, is liposuction used?
Yes, liposuction is very good. So your plastic surgeon friends can help it. I don't do it myself. I call the plastic surgeons.
Ma'am, there are 2 rates of your book seen on Amazon, 2,000 and 11,000.
Oh,
Must
one
be
is
the
Williams, other is
Springer. Springer is 11,000 and JP Publisher book I think is cheaper. I said one is the Teeland and one is the Datta.
Okay, okay. And
anything else? Yeah, I think where do you get the dermal cannula from? Trade name. Everyone wants trade names and names and address of the dealer.
We
This is the
cannot give it. Legally not allowed.
no issues, no problem, no problem. In the meanwhile, you can share your training course program to me on my individual WhatsApp so that I can also share it to the delegates. Okay.
Right. Thank you. Thank you so much.
Thank
Thank you.
Anything else, Veena?
no, sir.
Yeah. So thank you so much, Dr. Preeti and Dr. Ragini. We really look forward to visiting your place at some time or the other. Yeah. There's last question. Through the same cut for both sides or different cuts?
Different cuts, just very close to each other. Right on the right side of the posterior faucet, left on the left side of the posterior faucet.
Okay. Okay.
Some people do it from the top also, but somehow I don't like that. Yeah.
So anything else? Okay.
अभ्यास करू दे मला.
अरे बापरे.
केलं मग बंद.
Mukta, mute yourself. So Dr. Mukta happens to be our past president of POGS, and so you can see the dedication with which all
Yes.
166 people have logged in.
Yes.
Dr. Preeti ji, we have about 180 registrations,
Wow.
and about 85 are from outside Maharashtra.
Very
So
nice.
really very
Many
nice.
congratulations to you. I mean, this is your hard work and this is your reputation. Very
So that is of the 16 coordinators that I'm having, and Meenal is of course one of them. Meenal, Parul, and Dr. Kaushik Dey hai. There are so many people.
lovely.
Thank you.
Lovely.
Thank you.
And thank you and good night. Thank you.
Good night. Good night.
I'm here only. I will be hearing, but then I'm
Yes,
just.
yes. So Meenal, can you introduce our next speaker?
So Dr. Shruti is going to introduce our next speaker.
Okay. So Shruti,
Dr. Shruti, please.
Yeah. Hello everyone. So, thank you, Preeti ma'am, for such a lovely talk. It was quite enlightening. So, welcoming our speaker, our next talk is going to be on labia minoroplasty, and our speaker is Dr. Mayuri Kochiwala. She is a senior consultant at Skin Eva Clinics, Jaipur. She is founder and director at the Institute of Interventional Dermatology and Aesthetic Gynecology, and she's also a training faculty at for fellowship and diploma hands-on training in aesthetic gynecology. Over to you, ma'am.
one thing about Dr. Mayuri, we have heard a lot of things about the excellent training program that you hold, especially the hands-on program that you are conducting. So really look forward to what you are going to say for your today's talk.
So much, sir. I hope I'm audible.
Yes, ma'am. Yes, ma'am. You are audible.
So much for your kind introduction. Can I now share my slides? Yeah, is it visible?
Yes, ma'am. They are visible.
Okay. So thank you, everybody. Now let us, as everyone knows that the topic of my presentation is labia minoroplasty. As very well discussed by Ragini ma'am and Preeti ma'am, we all now know that labiaplasty surgery is a cosmetic and reconstructive gynecological procedure that addresses concerns related to the size, shape, and symmetry of the labia minora. As a gynecologist, labiaplasty is a valuable tool in our practice that can allow us to contribute to the holistic care of our patients and improve their quality of life. The American Society of Aesthetic and Plastic Surgeons they reported that the request for labiaplasty increased by more than 200% from 2015 to 2020, and the reasons for the increase in the procedures were the cultural shift towards increased openness and discussions about intimate topics that contributed to greater awareness, the media portrayal of idealized bodies, including those in the public eye, and social media that influences the beauty standards amongst our patients, the ease and access of information, particularly through net and social media, which has empowered individuals to learn about various cosmetic procedures, and the reduced stigma surrounding the cosmetic procedures and improved surgical techniques and safety. So, although there is no globalized standard aesthetic ideal, but there are variables according to cultural and geographical preferences of the patients. But at the back of our mind, whenever we are doing any surgical procedure to our patient, the basic guidelines that we should follow include symmetrical labia minora that do not protrude beyond the labia majora, especially when in standing position, clitoral hood that is reasonably short and not protuberant without extra folds, The labia majora should be full, but not it should be without extra redundant skin, and not overly fatty also, that causes unsightly bulge in the clothes, and the mons pubis, which has mild fullness but doesn't protrude in the clothes. So the indications can include medical indications like chronic discomfort, irritation, pain during enlarged or asymmetrical labia minora during physical activities, daily activities like walking, exercising, running, and difficulty in maintaining a proper local hygiene for the patient, leading to recurrent infections and irritation. There can also be labial hypertrophy, which is defined as more than 4 centimeters of the labial width, which is a medical indication for labiaplasty, and women presenting with recurrent infections due to the increased size, which leads to difficulty in maintaining a proper hygiene. Aesthetic indications can include labiaplasty where the patient wants a desire for symmetry. Like this photo is of my patient. She came back in like 2 years back to me from Dubai just for this little asymmetry, and this is her after picture. And it made her confident and look better. So if any patient presents with a little asymmetry also, and it can help improving her emotional distress or body image, then we should proceed with these surgeries for the patient. They can also present with desiring a specific aesthetic look that aligns with personal preferences or societal ideals, and clothing and comfort, like labiaplasty. If you provide labiaplasty and if it is helping her to wear certain types of clothes without feeling self-conscious, then we can offer these kind of surgeries to her. Contraindications include body dysmorphic disorder, severe anxiety, history of intolerance to pain, major medical or surgical illnesses, and back injury. Anatomy, as everybody has discussed, a thorough understanding of the anatomy is of paramount importance to avoid clitoral nerve injury and prevent post-operative sensation deficits. Normal labia minora anatomy encompasses a broad range of sizes, thickness, and colors. So it is important to understand the anatomy. The glans sits directly under the prepuce, and the frenulum are the folds of the skin that extends from the glans and merge with the clitoral hood to form the labia minora. And we should know that natural asymmetries in other areas of female genital aesthetics, genitalia, are extremely common, that most commonly in the clitorolabial complex. And the way the hood inserts or blends into the labia minora, it can vary amongst the patients according to the thickness, edges, corrugations, pigmentations, etc. So most women who present requesting labiaplasty typically have a very specific anatomical variant in which the labia minora are overly prominent. Either it is the, you can see in the image, either it is in the anterior, on the middle, or the posterior aspect of the labia minora. Uh, Infrequently, you can also find one labia slightly more protuberant than the other, causing an asymmetry. Similarly, the length of the most prominent part of the labia can vary amongst each side. The blood supply comes from the posterior labial artery, and the internal podental artery gives rise to the labial arteries, which leads to further branching. And there is segmental blood supply within the labia minora, with one dominant central artery, one anterior, and two posterior arteries. And disrupting the segmental blood supply and connections between anterior posterior arteries can be responsible for wound dehiscence, and especially from wedge excisions, which is one of its most known complication. So essential preoperative assessments before labiaplasty include a detailed patient counseling discussing the patient's motivations, expectations. We should provide the information according all the surgical procedures that we can offer to her. Realistic expectations and limitations of each procedure should be explained beforehand. Detailed medical history of any chronic medical or surgical illness, allergies to medications, any ongoing medication the patient is taking, and history of bleeding disorder should be ruled out. Detailed examination of the labia minora and surrounding genital structures for their symmetries, any abnormalities should be done beforehand. Identification of any pre-existing condition that might impact the surgical plan, like a pre-existing asymmetry. You should always tell your patients about that beforehand, otherwise they will blame the surgery for that asymmetry. Photographic documentation is very important for each and every patient. Blood tests include minimal work with infection tests like HIV, HBS, complete CBC, and additional tests for blood evaluation of blood clotting functions. This is the most important part, informed consent. We have to clearly explain the nature of the labiaplasty procedure, including the chosen technique. Whether you are doing a trim, wedge, deepithelialization, or any other XYZ technique, you have to explain your patient what expected outcomes she will have and potential aesthetic changes that she will have in the post-operative period. A comprehensive list of potential risks and complications should be explained beforehand, like infection, hematoma, scarring, nerve injuries, and all. Alternative options for her, like non-surgical, ma'am said the non-surgical options are available, or you can, in minor cases or mild cases of labia hypertrophy, you can augment the labia majora rather than going for labia minora plasty. You can augment the labia majora, which will hide the labia minora inside. So alternative options are always there. You have to explain to your patient what anticipated benefits she can have after the surgery should be explained. And post-operative care, because these are newer techniques, so post-operative care should be clearly explained to the patients according to the hygiene, dressing, how frequently she has to take the antibiotic, whatever she asks. Anesthesia information is very important because I do all my cases under local anesthesia, so it is important to take an informed consent for that. And follow-up appointments, when she will have the appointments, how frequently she will have to visit. Photographic documentation, whether the photographic documentations, what all purposes the photographs will use for. There should be a proper consent from the patient. You cannot use her photos on social media and other things without the consent. Then pre-operative instructions, what I give to my patient, because they are done under local anesthesia, they have to come, they have to eat something and then come for the surgery, because fasting is not required. The medications I take care, whatever is not required, I stop them before 7 days. Information on the hygiene practices, she has to take a bath, and what all to expect, what not to expect before surgery, on table, and after surgery is informed beforehand. So step-by-step procedures, I'll explain you. Preoperatively, I examine my patients in the lithotomy position. You can use a mirror, handheld mirror, or a live real-time camera. I generally take the photographs in the mobile phone after consent, and then I'd sit with my patient on table and discuss what her expectations are, what can be done in this case, whether a trim, whether a wedge, whatever suits her, that has to be discussed. A surgical markings will depend basically on the patient's specific anatomy. The hood is also evaluated to determine the position. It is very important, even if she has come for a labia minoroplasty and you think that the hood might be protuberant after resection of the labia minoroplasty, you have to explain her beforehand. Otherwise, it will land up in like a creation of a mini penis kind of thing that remains protruding even after correction of the labia minora. Any extra folds in the hood, everything has to be discussed. The posterior introitus is also a point to be taken care of. It is if the labia are joining in the posterior part on the posterior foresheet, it might cause a dyspareunia later on if we go for the correction. Virtually all labiaplasties can be performed under local anesthesia, and topical anesthesia cream can be applied beforehand before giving her the local injectable local anesthesia. That reduces the pain further. And a dose of oral antibiotics is given at least 30 minutes to 2 hours prior. All the procedures are performed in the lithotomy position, and markings are the area asked to be, which is to be excised, is to be marked considering the patient's desired anatomical variations and the chosen technique. The markings, very importantly, must be made before the injection of the local anesthesia. Otherwise, it will lead to distortion and we will not be able to mark adequate resection. And whatever you have marked, take, as I say all the time, whenever students come to me, I tell them to take 15 minutes, 20 minutes before starting the excision part. Take 20 minutes to mark, be confident in your markings, and after that you proceed with your procedure. It will not take much time, but stop or uh, avoid deviation from the markings, avoid otherwise you will land up in complications. So the incision lines are injected with, you can take 2% lignocaine with, mix it with bupivacaine also to increase the potency. Tissue removal for the surgical intervention is again that according to the technique you can choose. I'll come to that. The types of labiaplasty. After the resection of the tissue, hemostasis is achieved by layered closure, or if you have a cautery device, you can coagulate. Post-operative care, clear instructions should be given to the patients, and we should address all any complications promptly. So we can do a labiaplasty with hundreds of techniques, but the most commonly used techniques are the rim or the edge resection and the wedge resection. Deepithelialization is not very common. In the trim technique, the asymmetric or protuberant labia minora are corrected by excising or trimming the excess areas with knife, scissors, lasers, radiofrequency device, anything. It is imperative to leave 1 centimeter cuff to retain a functional seal of the introitus. It is very important. Otherwise, we'll give a, either if we over resect, we will give a gaping look or amputated look to the introitus, and that will not be desired by the patient. This trim technique is best for marked redundancies, excessive thickness when patient is accepting potential change in the color of the visible edges. Again, you have to discuss with your patient if she is willing to, as ma'am said, that it will lead to the excision of the dark colored labial edges, and it might not be acceptable in some of the patients. Advantages are short operative time and creation of light colored labial edges. In the trim technique, the elongated edges are being removed via edge excision, and suture line is at the edge of the labia minora. Whatever is protuberant part, you either it is anterior, middle, or the posterior part, you can excise that, and the suture line comes in the edge of the labia. Sometimes the natural corrugations are also being removed with this technique, which leaves the edge partly corrugated and partly smooth looking, which might not always be desirable. So these points need to be considered and discussed with the patients beforehand. The trim incision is started at least 1 to 1.5 centimeter below the frenulum, and is extended down to the introitus, depending on the precise location to which the labia minora is attached. And the tissue can be substantially debulked by making angled incision. See, we do not have to cut it straight away, medially and laterally. We have to like keep our whatever the cutting device is, laser or radio frequency or knife or whichever mode you are cutting, you have to keep it at an angle of 45 degrees, both medially and laterally, so that it creates a canal kind of thing, wedge kind of thing is created along the edges of the labia, which will help in the coaptation and the closure of the edges. It gives a very good aesthetic result afterwards. And later on, once you are done with your cutting part, then the top and the bottom part of the edge or the incision has to be trimmed with, or you have to make an A incision on the top part and a V incision on the lower part, so that it closes beautifully without leaving any dog ears or protuberance in the scar line or edges. So again, according to the, as you can see in this diagram, according to the amount of tissue resected, it can be either a rim labiaplasty, hybrid labiaplasty, or a Barbie look labiaplasty. Barbie look labiaplasty is not very preferred, and hybrid is the most commonly demanded by the patients in our scenario. So the layered closure is done by either a 40 or 50 monocryl, which is best for deep suturing, as it resists premature suture breakdown, as is seen with the other sutures like vicryl. And rapid vicryl is ideal for the last layer for either interrupted or continuous sutures, because they do not poke the surrounding tissues. Now, the principles during closure that we should keep in our mind, that deep dead spaces should be closed gently, but the closure should be loose but secure to reduce the clumping of the tissue and rigid edge scarring. And the skin should not be entrapped to cause any inclusion cyst later on. Deeper stitches you can do anyways, like either it can be interrupted stitches or continuous, but not locking. They have to be continuous, simple continuous stitches. And later on in the skin, you can take again continuous or interrupted stitches using a rapid vicryl. The second most common technique is the wedge technique championed by Dr. Gary Alter, and it preserves the natural edges of the labia. As you can see in the image, whatever the most prominent part is there, we have to create a wedge or V, and then we again approximate the remaining anterior and the posterior margins, which gives a natural labial edge. But the disadvantages are the longer operative time and required surgical expertise, with more chances of dehiscence and persistence of dark labial edges, which might not be accepted by some of the patients. But okay, the wedge, the markings are done when the patient is in the lithotomy position before the infiltration of the local anesthesia. Otherwise, the swelling will distort the anatomy and lead to over or under correction. Again, the point is that the V the peak of the wedge should be positioned mirror image of the most prominent anatomical variant. So either the wedge resection can be anterior, posterior, or the middle wedge resection according to the protuberance of the labia minora. And the position of the scar varies according to the incision where you have given anterior, middle, or posterior. The scar eventually settle very well and eventually look quite inconspicuous even as early as a few weeks of the procedure. So V-shaped droid should be made, and we should not place again the angle or the point apex of the V too close to the urethral meatus to avoid distortion of the meatus leading to spraying of the urinary stream. Coaptation of the edges with minimal tension is of paramount importance. The most important thing in the wedge resection to decide is how much to resect. If you under resect, it will not give a good aesthetic result. If you over resect, it will cause the suture line to be under great tension, which will result in complication and suture breakdown. So we should be centralized around the most prominent part, and degree of excision should achieve straight, non-redundant labia that is approximated under no tension. The care should be taken to ensure that you do not over-resect or cause an overly tight introitus. In wedge, one complication is also because you are resecting it anterior-posteriorly, when you close the wedge, it might lead to lifting of the posterior fourchette and causing an introital tightening. So we have to keep two fingers inside when the subcutaneous, again, the closure should be in 2 layers at least. The subcutaneous layer is closed separately using 4-0 monocryl or bicryl, and the medial and the lateral edges are closed separately using 5-0 either monocryl or rapid bicryl. And at the end of the closure, there should be only one small transverse incision line, as you can see in the image, and the labia should not protrude past the introitus. The last common technique is the demucosalization, where we can offer this for very atrophic or thin labia, which is in which the wedge is not completely removed in full thickness, rather it is demucosalized, and both medial lateral sides of each lip are marked to delineate excisable areas, and both sides are de-epithelialized or skin. As you can see in this diagram, it is not the subcutaneous tissue is preserved, so that the vessels, the theory is that you preserve most of the arterial supply and it will lead to less complication. And this technique is advantageous only if we have to remove minimal amount of labial tissue. It can interfere with the blood supply because it is very thin. If you inadvertently puncture it or takes deep sutures, it might lead to holes, like you can see in the lower image, fenestrations or holes after the healing. So to compare, the edge excision is technically simple, adaptable to all labial sizes, very easy to learn, and wound dehiscence is very rare. It doesn't require revision surgery as common as in wedge excisions, but wedge is superior to edge excision because it preserves the labial edges and eliminates the possibility of scalloping or scarring. You have to decide your own technique, whichever suits you, you can go with that. Each technique has its own advantages and considerations, and the choice depends on patient's anatomy, preferences, and the surgeon's expertise. As I said, I performed all the procedures under local anesthesia using RF or CO2 laser, and a layered closure is done for all of my patients. So this is a patient of linear labiaplasty or edge resection. Here, first of all, you have to be very confident with your markings, and you have to replicate your markings on both the sides equally so that you get symmetrical results. So once you are confident with the markings, take as much time as you want with the markings. Don't deviate from your markings later on. Once you are confident with your markings, once you have done your markings, then you infiltrate the local anesthesia and you start cutting. The cutting this is the RF radio frequency device which I'm using because it is very fine and controlled cutting is there. So I get good results using these devices, but you can use a knife or a scalpel or a scissors. So this patient, as you can see, the top part is also very bulky. I did a hood reduction also for her. You have to decide according to your patient's anatomy, what is needed. Most of the patient don't know about the hood plasty or hood resection, and you have to guide them that if they don't undergo that, it might lead to a top heavy look, which will not look aesthetically pleasing. Then once in the subcutaneous tissue, you can use your cautery device to coagulate the major vessels and achieve hemostasis. So now, once the resection has been done, I am closing this in 2 layers. This is the submucosal or subcutaneous tissue which I am closing using a 4-0 vicryl. You can use a monocryl also. This kind of tissue is removed and excised. So see, this is a post in local. This is on table. You will see so much of edema, and because of I have done it under local anesthesia. So this all inflammation subsides in next 4 days, and this is a 2 months after picture of the patients. This is a case of wedge labiaplasty. Here I have done, you can see the mark. This is the posterior wedge resection. Huge labia. Again, a clitoral hood reduction is required in this patient. Again, I'm using a radio frequency device. You can choose whatever you like. These devices make the life very simple because of the controlled cutting and less bleeding. If you cut it with scalpel and all, the bleeding will be challenging to it will be challenging to be manage the bleeding part of the surgery. And ultimately, as I say, it's very important in aesthetic surgeries to control the bleeding beforehand, because once it starts bleeding, then we all, being an gynecologist, we all land up in managing the bleeding part and we forget about the aesthetics. So this is again a layered closure. I'm closing the clitoral hood. Similarly, I'll close the wedge resection also, and 4-0 vicryl in the deeper layers. And this is an immediately after picture. It doesn't look very good because of the local, but after 2 months, it's very difficult to make out where the suture line was. So these are the pre-post images that you need to show to your patient as well as to other patients after consent, so that they understand what labiaplasty is, and it's like easy for you also for conversion if you have such images. So post-operatively, what is important is clean the genital area with mild soaps and lukewarm water and avoid harsh cleansers that can irritate the site. And after cleansing, pad drying and applying an antibiotic, local antibiotic is important. It's important to avoid soaking and refrain from prolonged sitz bath or hot tubs during the initial days of recovery. Dressing, I don't do dressings, but you can do dressing for your patients. Antibiotic ointment, and keep the incision sites covered with sterile gauze if you like. The patient should choose light fitting clothes under comfortable underwear to minimize the friction and irritation. The pain management part, because it is a very sensitive part, so patients usually complain for next 2 to 3 days of mild to moderate pain, for which you should beforehand, before her telling the complaining about the pain, you should prescribe her some oral antibiotics as well as painkillers round the clock. You can use narcotic analgesic for 2 days, and the most important tip is the usage of ice packs. I advise all my patients to use an ice packs every 15 minutes for the first few days. 15 minutes of ice packing. Whenever she feels pain, she can apply the ice pack. Otherwise, also to reduce the swelling part and pain part, she has to use ice packs for next 24 to 48 hours, every 15 to 20 minutes. And elevating the pelvis slightly while resting might also help in post-operative discomfort. The ample time should be advised for rest during the initial days, because these are the sutures, very fine suturing you are doing using 4050 vicryl, and it is a very means the area is very sensitive. Plus, during walking, heavy running, or leg stretching, the sutures might break. So, ample time for resting should be advised to the patient, and refrain from strenuous activities, heavyweight lifting for first few weeks should be recommended to the patients. Gentle movements are advised, but the undue pressure should not be put on the suture line. So now coming to the complications, as in any other surgery, infection is a very risky complication.
Dr. Mayuri, you are locked out.
Ma'am, your microphone is on mute.
Hello, can you hear me now?
Yes, ma'am. Yes, ma'am, we can hear you.
So infection, then hematoma can present like swelling and bruising that progressively increases. There is tenderness and pain around the surgical site. As we manage any other hematoma, drainage and aspiration is important, and then post-operative care to minimize again the risk of hematoma. Scarring abnormalities include leading to hypertrophic or keloidal scar, changes in the pigmentation. Scar creams, scar revision surgeries are the management options. Wound dehiscence, like in some techniques, we have more number of wound dehiscence chances. So again, we have to do revision surgeries, and we should stick to our post-operative care instructions for our patients. Nerve injuries can be there, like littoral nerve, if injured, will lead to either numbness or hypersensitivity in that area, leading to neuropathic pain. Again, we have to manage with supportive measures, or if not responding, refer to a specialist for pain management. Asymmetry is a very common complication, and we should take consent from the patient. We should inform her beforehand that whatever techniques we use for her, we choose for her, asymmetry can always be there, and natural asymmetries in labia are always there. So this should not be a point of consideration post-operatively, unless until it's a very bad asymmetry or greater degree of asymmetry. Again, revision surgery will be required for correction of any asymmetry. Delayed healing, prolonged redness, swelling, discomfort beyond the expected time, uh, persistent pain, worsening of pain, neuropathic pain. These are all theoretical complications which I have honestly never seen till date. So to conclude, it is impossible to define the ideal aesthetic landmarks on the external female genitalia because because of such great anatomical variations which exist among all females, and it requires excellent judgment on the part of the surgeon and full communication between patient and surgeons to provide best outcomes. Surgical techniques depend on the patient's anatomy, preferences, and the surgeon's expertise, and excessive resections can lead to disastrous results that might not be correctable. So think thrice and then cut once. This is the only thing that I will advise you all. Thank you so much for your patient hearing.
Thank you, ma'am.
Yeah.
So, would you like to add anything?
Dr. Mayuri, just a small question. Which patients do you select for wedge labiaplasty and which one for the linear labiaplasty?
Yeah. So honestly, for all of my patient, at least 99% of my patient, I prefer doing a curvilinear labiaplasty because I am more confident in that, and I have very beautiful results with curvilinear labiaplasty. A very few patients who themselves have read some Google or something, like they are well educated, they have read somewhere that wedge is more beautiful or whatever. It's their preferred choice. Then only I will go for a wedge resection. Otherwise, curvilinear fits for all kinds of labias, all sizes, shapes of labias. It's just that the clitorolabial junction that requires a special attention with where A incisions or the dog ears need to be reduced. Otherwise, curvilinear is very easy to learn with short operative time, and I'm more confident in that, so I offer that only for most of my patients. There is no specific indication where only curvilinear or only wedge should be done. But yes, if the patient is well educated and demanding a wedge, then I'll go for a wedge.
Can I add something, Dr. Kiran?
Yeah, sure, Dr. Preeti.
Very nice presentation, Mayuri, and beautiful work you're doing. Just a few things that, yes, curvilinear is good, but I always prefer wedge. It's difficult to learn, but then the results are much better. The chances of those hole-like fenestrations which you see are much less if you do a wedge resection. And Yes, in the beginning, one can go for trim or curvilinear, but then everybody should try to move to wedge as much as possible. It gives much better results, much more aesthetic, and the chances of blotched surgery are less. I really tell you, I'm much more confident doing robotic hysterectomy than doing a labiaplasty. In that 2 centimeter labia, if it gets blotched, you do not know what to do. If there are holes formed like ear holes, they are formed, you are actually in a total fix. Of course, I'm sure everybody is very good surgeon and they will fix it somehow, but then it's really very taxing. With wedge, actually, if you are very careful and you are suturing well, I've never seen any complications even from the starting days. And also one more thing, second point, that at times it may not be able to do it in 2 layers, though we always say do it in 2 layers. But at times you just follow your surgical aesthetics, just like you are doing your cesarean or whatever. Same way, do not get scared with it. So if you have cut the labia as a wedge and you have to stitch it, if there is more tissue, you will go for 2 layers. If there is not too much of tissue, go for a single layer, but just avoid the tension in between the tissues and good hemostasis. That is what I have seen. It works very well. Thank you so much.
Yeah, Dr. Preeti, coming
Definitely,
to
ma'am.
it,
It's
and
totally up to
Dr.
the
Mayuri
surgeon.
also. Yeah, what are the chances of having dog ears at the apex for a wedge resection?
Very less.
Well,
Very less. Also, and wedge the, so when you hold mark the wedge, and very good practice point is approximate both of them. So you will get a mirror image of this wedge, and then cut it and you will get a very nice symmetry. And wherever tissue is more, just follow your one point for the blood vessels.
Yeah.
Just put a dot and you will see lots of blood vessels. Right? So you have to try to retain as many blood vessels you can. Learned where losses. And if I was going all through, how is it possible to cut it? I used to wonder how will I not cut it? Of course it will get cut, but there are lots of anastomosis. It heals very well. And I do it under general anesthesia because I don't want my patient to be shaking that time because it is a demanding surgery. More than the physically demanding, it is mentally straining surgery. I want my patient to be relaxed, and anesthetist to look after the pulse, BP, and pain so that I can concentrate on cosmesis. But then, as Mayuri is doing such wonderful job under local anesthesia, it's perfectly fine.
Can these surgeries, the plasties, be combined with a vaginal hysterectomy?
Yes, it can be. It can be if required. Yes, but usually the vaginal hysterectomies are normally. I do more of perineoplasty, which you all do it anyways, rather than the labiaplasty. These women are usually little more aged. But if you have in younger people prolapse and vagina, and you are doing non-descent vaginal hysterectomy for some whatever reason, then yes, why not? It will be a good idea.
Okay. Can it be done under saddle block? Yes, it can be done under saddle block.
Yes, absolutely. Absolutely. If you have overnight stay facility or daycare where you can keep the patient for a longer time, yes, why not?
I would like to add a point, ma'am and sir. Whatever setting I am working under, I have seen that my patients particularly are very comfortable. Even if I give them an option of GA or spinal or saddle, they choose a local over that because these are unmarried girls. They just cannot come out of their homes for complete day and all. They get the surgeries done, they go back home immediately for like observation for 1 or 2 hours, and they go back home. So this is my opinion. Baki to you can do everybody saddle block, spinal, anything you can do.
Correct.
Local is possible, to everything is possible.
Correct. Correct. Absolutely correct, Mayuri. Absolutely correct.
Okay, there's a very practical question. In the marking of the wedge, how do you measure the length of the wedge? That is, yeah, how to end at the
As
apex.
ma'am said, either you hold two forceps or two LEs, and then you just approximate them and just see the suture, the line that the suture line which is coming to be there should not be under over tension, or it should not give a under corrected look. That is the only thing that you have to decide upon.
Correct. And also it should not protrude beyond labia majora after doing the labiaplasty. That should be the aim.
It's always better to undercorrect, even if you cannot decide upon resect less, and then you can always keep on refining the suture line. Like you make a small V, and then if you feel that when approximating that, if it is protruding beyond the labia majora, you can again increase your incisions. But if you over resect, that will be very difficult. It will give away if you the suture under pressure or under tension. So it's better to undercorrect, and then you keep on refining it.
Okay. Any other questions, Kaushik? Any other questions from your side?
So there's one more question. How to avoid nerve innervations while doing the wedge resection?
It's not about the wedge or this curvilinear. The nerve, the clitoral nerve, basically that is only most commonly injured nerve if you're not taking care of the plane. So the video was very fast, because I had to cover it in time. Otherwise, if you see it in detail, the when I'm resecting the clitoral wood, that is a very thin layer of skin. Only the skin you have to resect. You don't have to resect the underlying tissue or subcutaneous tissue. You have to be as superficial as you can be in the clitoral this resection area. There is only because the dorsal nerve of clitoris is very superficial in that area, and there only it can be injured. You don't take your during suturing also, don't take very deep bites. Just you have to approximate whatever you have resected, and don't go too deep in suturing as well as in cutting. That will preserve your nerve. And obviously over the clitoris in classical or any kind of U-shaped or V-shaped clitoral hood resection, there is no need to give incision directly on the top of the clitoris, because that is the path of the clitoral nerve. Otherwise, in labia minora, there is no risk of injuring any nerve.
Perfect. And also, clitoris is a confluence of more than 100 nerves. So, basically, why we have to be little more superficial is not that she will not have any nerve sensation. Basically, if the nerves get injured, then she may have CCRs. But otherwise, there are so many nerves. That's why the clitoris is the most erogenous organ in the females. So, we don't actually really need to worry about the too much about the nerve injury.
Any other questions?
No, sir. I think all have been answered. Only few participants are requesting for a video of the procedure.
I think Dr. Mayuri, if at all you have an edited video, you can share it in the group, or you can share it to either myself or to anybody, and we will share it in the group. Or even Dr. Preeti ji, if at all you have any video, आप अगर वीडियो भेजते हो तो we'll share it in the group.
Tomorrow I will send.
जी
Tomorrow in my
जी
clinic, from there I'll send.
जी.
Sir, I am not added to any group. I just received your message just right now. But I
No,
am
no,
not
no,
in
no,
any
no.
group. I'll share it.
Yeah, share it to me, no problem at all. Nobody's added to any group. We are going to add everyone to the group later at the end. Don't worry. Don't worry. Huh? In the meantime, Dr. Mayuri, you can also share the flyer if at all you have any flyers, so that we can share it in the group. Yeah. So any other
Okay, sir.
questions?
Thank
So there's one last question.
Oh,
Suture knot should be towards which side?
you. What should be?
the
Suture.
knot, the suture knot. So it should be inside or it should be outside. That is what they mean. Towards the vagina or towards the majora.
Like in which, if you are doing a curvilinear, then the knots will be on the top, on the edge. And if you are doing a wedge, you have to close into the medial part separately and the lateral part separately. So the knots will be inside Half of the knots will be inside, half will be lateral.
Okay.
I think we are done with all the questions, sir.
Yes. Okay.
Yes, sir.
So thank you so much, Dr. Preeti, Dr. Mayuri, and really look forward to meeting all of you. And in case you have anything to share, please share it with me or with anybody, with Meenal or with Shruti or with anybody, so that we can share whatever knowledge you have given to the group.
And thank you so much. It was so lovely. Thank you, Dr. Kiran
Thank
and
you.
whole team. You all were so lovely and it was a great experience. Thank you
Thank you,
so
ma'am.
much. Thank you, Mayuri.
Thank you.
Beautiful presentation.
Thank you.
Thank you so much. And looking so forward to welcoming you in Chandigarh City Beautiful in August.
Sure.
Bye-bye.
Thank
Good
you,
night.
Thank
everyone.
you. I'll be
Thank you,
closing the
sir.
meeting for
Thank
now.
you, ma'am.
Thank you so much. Thank you, ma'am.